Hello, I'm Alina Solganikov, Senior Vice President and Director of KFF's Program on Women's Health Policy. I'm delighted to welcome you today for the public release of some of the findings from our newest Women's Health Survey, as well as a discussion of the policy implications of the survey with really a distinguished panel of national and state leaders and experts in sexual and reproductive health, whom I will introduce to you shortly. We have a lot of ground to cover today and not a lot of time. But before we get started, I wanted to just do a bit of housekeeping. Next slide, please. I want to remind the audience that this web briefing will be recorded. The archive recording and the slides will be posted online, and everyone who RSVP'd, those of you who are here today, will receive a notification when they are posted. The webinar is in listen-only format, but you can submit questions for the speakers at any time during the web briefing using the Zoom Q&A function. We're going to leave some time at the end of the panel to take a few questions. Last week was a big week in women's healthcare with many developments that hold the potential to shape access to women's sexual and reproductive healthcare into the future. The Biden administration issued new regulations for the federal Title X family planning program, essentially signaling the end of the Trump administration's so-called gag rule. The FDA temporarily suspended the in-person requirement for dispensing mifepristone, the medication abortion pill, allowing for the resumption of telehealth abortion in many states. And we marked Black Maternal Health Week, capped off by the first approvals of one-year extension of postpartum Medicaid coverage. Of course, we're still waiting on the Supreme Court to make a ruling on the ACA and to dismiss the Title X cases, as well as the possibility that the High Court will take an abortion case that could reshape and further restrict abortion access in many states across the country. My colleagues Usha Runji and Brittany Fredrickson will present some of the key findings from the Women's Health Survey as they relate to the pandemic and also sexual and reproductive health. Brittany and Usha, along with Michelle Long, have been working on this survey for well over a year. We will then have a discussion with Cami Jeffrey, Sue Kendig, Doctors Monica Mclemore, and Reagan Mcdonald Mosley, and I'm going to introduce them in a little more detail shortly. So with that, I'm going to turn it over to Usha to get us started.
Thank you, Alina. Hello, everyone, and thank you all for joining today. We are all so excited to be able to present findings from the 2020 Kaiser Women's Health Survey. And today, first, I want to start with a little bit about the survey itself. 2020 Kaiser Women's Health Survey is the latest in a periodic series of surveys that we actually started conducting in 2001 on women's health and access to care. This year, the survey was included a sample of just over 3,600 people who identify as women, as well as a shorter sample of a survey of people who identify, over 1,100 people who identify as men. We fielded the survey late last year, mid-November to mid-December. We worked with the company NORC, which is an independent research institution. They conducted the field work and drew the sample from their probability-based AmeriSpeak panel. More than 95% of survey respondents answered online, either in English or Spanish, depending on their preference, and a small share of respondents answered the survey by phone. In addition to reporting findings on the full populations of women and men, we were also interested in many subpopulations. So we oversampled women ages 18 to 49, as well as those who are uninsured, Asian, and lesbian. And one note, we will be releasing more data soon on LGBT women and men. This margin of error for the full sample of women is plus or minus 2%. So I want to start with I'm going to really focus on findings related to the impact of the pandemic on women's access. And first off, we found that many women reported skipping healthcare services, and this was higher among women compared to men. Almost a quarter of women say that they skipped a medical test or treatment, as did 15% of men. You can see that in the orange and gray bars. And almost 4 in 10 women and a quarter of men skip preventive care, like an annual checkup or a routine test. One of the concerning patterns was that these rates were higher among women in poorer health. So nearly 1/3 of women who rate their health as fair or poor skipped recommended tests or treatment, and almost half skipped preventive care. Those in poorer health may be at higher risk for severe COVID and may have opted to skip routine care. And now, though, as we begin to turn a corner on the pandemic, providers may need to think about the possibility of seeing an increase in patients with more severe conditions that result from care that they skipped or missed during the pandemic. In fact, over a quarter of women in fair or poor health said that their condition got worse because they weren't able to get the care. Next slide, please. Now, one sector where there was a lot of growth was telehealth. You see on the left that just 13% of women said they had a telehealth visit prior to the pandemic, and rates were similar regardless of insurance status. On the right, you see that there was a sharp rise, with almost 4 in 10 women saying they had had a telehealth visit by late last year. However, just 20% of uninsured women, compared to 4 in 10 with either public or private coverage, had had a telehealth visit. There's a lot of discussion about the prospects for telehealth in the future. For example, we've heard about how it can be used to extend access to those who live in remote areas and have a harder time getting to a provider. But I think we'll really need to make sure that we're actually reaching all populations and that inequities that are already in the healthcare system are not widened. And going forward, women may want to have a choice between telehealth and in-person care. Now, women had telehealth visits for a variety of reasons, as you can see here. One promising sign is that in general, women gave their telehealth visits pretty high marks. Nearly half of women who had a telehealth visit for either mental health care or care of a chronic condition rated their last visit as excellent. Most who had used telehealth for COVID-related care or a well woman visit said their last visit was good or very good. About 1 in 10 did rate their most recent visit as just fair or poor. So as telehealth grows, we will need to learn more about quality and how to measure it, as well as patient satisfaction, which will really speak to the long-term viability as telehealth as an option for reform and for women across the board. In addition to the health and healthcare impacts, the pandemic has taken a large toll economically, both from a macro level, but also for many people on an individual level. Almost a quarter of women reported that they had trouble paying medical bills last year. Among that group, 42% said that problems with their medical bills were due to an issue that they were already experiencing prior to the pandemic. A quarter of women, however, said that their problems with medical bills were a result of COVID and the impact of COVID on their financial situation. And another 31% attributed problems with medical bills to both an existing issue as well as COVID. So in addition to the health effects of the virus, a sizable share of women are dealing with the financial aftermath, which may be harder for providers to see, and again, reminding us that health and finances are so strongly connected. And the pandemic has certainly affected people's mental health with a disproportionate impact on women compared to men. Half of women and a third of men say that the pandemic has had a negative effect on their mental health. About a fifth of women characterize the impact as major. The numbers are very similar among mothers and fathers of school-age children. When we look by race and ethnicity, a smaller share, still over 4 in 10 though, of Black and Hispanic women said that COVID affected their mental health, compared to about half of Asian women and just over half of white women. This was surprising to me, given the disproportionate toll of the pandemic on Black and Latino communities. But given just these significant numbers overall and the importance of mental health, we really need to understand this area more and differences between communities. So those are just some highlights. We covered a lot of ground in this survey, and there is more on the impact of the pandemic in the written reports. But now I'm going to turn it over to Brittany, who is going to shift gears and talk about the survey findings on sexual and reproductive health care.
Excellent. Thanks, Usha, and hello, everyone. I'll be presenting some of our main findings from the survey on sexual and reproductive health services. And these findings are specifically focused on women of reproductive age 18 to 49. Through this section of the survey, we were interested in looking at how and where women were accessing their sexual and reproductive health care and what kind of care they were receiving. One of the first things we wanted to know is how many women have had a gynecological visit in the past 3 years. You can see most reproductive age women had one in the past 3 years, but this was substantially lower among younger women, Asian women, and less than half of uninsured women had had a gynecological exam in the past 3 years. These women may be going without important breast and cervical cancer screenings that could prevent negative long-term outcomes in the future. Another important component of the gynecological or well woman visit is provider counseling on a number of recommended topics. We found that the majority of women said a provider had asked them about contraception, though this was lower among Black women. However, only about a third of women said their provider had discussed STIs or HIV with them. Additionally, it is recommended that providers screen for intimate partner violence, but just over a third of women said their provider had asked them about IPV, and this was significantly lower among Asian women and Black women. We know that these are sensitive topics, and sometimes providers may feel that they are not equipped to provide services or support. For example, if a woman says she's experiencing IPV. We also know that providers are a trusted source for women on these health topics, and these conversations can be a start to addressing the issue and getting connected to resources. While many women are having discussions with their providers around contraception, we know that not everyone wants to use it. When we asked reproductive age women who reported having sex with a male in the past 12 months, the majority reported using at least one method of contraception, but 14% of women report not using any contraception. Nearly a third of women not using contraception said the reason they were not using it was because they were worried about or disliked the side effects. For this particular question, women could select more than one reason, and nearly a quarter said they didn't want to use birth control, and another quarter didn't really mind if they got pregnant. Many of these reasons could be discussed through client-centered counseling, and adequate evidence-based counseling around side effects can build trust between patients and providers and can help women both select a method that works for them and lead to method continuation. Regarding women's thoughts around pregnancy, when we asked about women's desire to avoid pregnancy, among contraceptive users, the top bar, the majority say it is important to avoid pregnancy, which is probably why they're using contraception. However, close to 1 in 5 contraceptive users say that avoiding pregnancy is not important, which speaks to the fact that women use contraception for reasons outside of pregnancy prevention, and women's opinions on pregnancy can change at any time. Interestingly, among non-contraceptive users, over a third said it was not important for them to avoid a pregnancy, but almost half said it was very important for them to avoid becoming pregnant in the next month. If these women are not using contraceptives because they are worried about side effects or some other reason, this leaves us with the question of how we can better support these women to achieve their reproductive goals. So where are women going to receive their contraceptive care? Lots of the policy discussion right now is around Title X funded clinics and Planned Parenthood clinics, but the majority of women reported going to an office-based physician for their contraceptive care, followed by Planned Parenthood and another family planning clinic, while only 2% of women reported going to an FQHC for their contraceptive care. Usha showed a slide showing that telemedicine has increased over the past year, yet only 4% of women report receiving their contraceptive care via telemedicine. There has been a rise in telecontraception apps like Nurex, the Pill Club, Pandia Health, and we are interested to see how women will use these new forms of contraceptive provision. We actually recently conducted a survey of these apps and we'll be publishing our findings in the near future, so stay tuned for that. There were differences by race ethnicity as to where women received their contraceptive care. Larger shares of Black and Hispanic women received their care at a clinic or other location like a pharmacy, drugstore, or some other place, compared to white women who largely received care through a doctor's office. We know that Hispanic women have the highest uninsured rate, and federally funded clinics remain an important source of care for these women. We were very interested in looking at the quality of care women were receiving at their contraceptive care visits, and we were excited to be able to include the newly endorsed NQF measure of person-centered contraceptive counseling on our survey. This was developed by Christine Dellendorf and her colleagues at UCSF. This measure asks women to rate their provider on 4 items of contraceptive counseling using a 5-point Likert scale, ranging from poor to excellent. And the measure is calculated as the percentage of patients who rated all 4 items as excellent. The items include respecting me as a person, letting me say what mattered to me about my birth control, taking my preferences about my birth control seriously, and giving me enough information to make the best decision about my birth control. Less than half of women rated all 4 items as excellent, and even fewer Black and Hispanic women rated their contraceptive counseling as excellent compared to white women, indicating there is additional provider training needed to ensure women have person-centered contraceptive counseling. By using person-centered contraceptive counseling, providers can better understand what someone's preferences are for their birth control. We found that nearly 1 in 5 women say that they are not using their preferred method of contraception. And this was significantly higher among uninsured women compared to women with private insurance. When we asked why they were not using their preferred method, a quarter said they can't afford their preferred method, and another 20% say they are not using their preferred method because their provider recommended a different method. This again supports client-centered counseling that takes into account women's preference. You will see that a large share gave other reasons, which was an open-ended response. And some of the reasons included not using their preferred method because they were currently breastfeeding. A number of women said their partner has been unable to get a vasectomy, some saying that it was because of the pandemic. There were also women that stated accessibility reasons, being unable to get an appointment or unable to get to a doctor's office, which is where telecontraception could be used to improve accessibility. There were also a number who said they were unsure why they weren't using their preferred method. Regarding affordability, the contraceptive coverage requirement through the ACA requires that most private plans cover contraceptive services, including patient education, counseling, and all of the 18 FDA-approved methods of contraception without cost sharing. However, 1 in 5 privately insured women is still reporting having to pay for part of their care. There could be a number of reasons for this. This could be because they're receiving out-of-network care. They could still be enrolled in a grandfathered health insurance plan, which are exempt from the requirements, or they could be covered through a plan by an employer that has a religious objection to contraception. With affordability being one of the main reasons women are not using their preferred method of contraception, we have more work to do to ensure women can get their preferred method covered without cost sharing. And even though most women are connected to the healthcare system, another interesting policy issue is the amount of contraceptive supply a woman can receive at one time. Laws have been passed in at least 17 states and DC that require coverage for 12 months of oral contraceptives to allow women continuous contraceptive coverage for at least a year. However, these laws typically only apply to fully insured plans, and many Medicaid programs can and do limit supply of hormonal contraception to 1 to 3 month periods. And self-funded employer plans are also permitted to do this. Shorter supplies can result in women missing their pills due to delays in receiving their next supply. And we found that 1/3 of hormonal contraceptive users report that they have missed taking their birth control because they couldn't get their next supply in time. This was higher among younger women as well as women with Medicaid. This is an accessibility issue that could lead to long-term negative health outcomes. In order to make contraception more accessible, there has been a lot of momentum before and during the pandemic to make contraceptives more available through local pharmacies. And the majority of women are comfortable with pharmacists prescribing birth control and support making contraception available over the counter without a prescription if the FDA said it was safe and effective. This was largely supported across party lines, with Democratic and independent women supporting this more compared to Republican women. And this could help address some of the accessibility issues by allowing women to access contraception from their pharmacy without having to schedule a clinic appointment, take off work for this appointment, and wait to receive their prescription or supply. I'm excited to hear from our awesome panel on some of these policy issues that could really change sexual and reproductive healthcare provision. And with that, I'll pass it over to Alina to introduce our panel.
Thank you so much, Brittany and Usha. Before we start the panel, I do want to invite the audience to submit questions about the survey or topics through the Zoom Q&A function that's at the bottom of your screen. As I mentioned earlier, we're planning to leave some time at the end of the panel to take a few questions. Don't put your questions in the chat function, please. So before we launch into the discussion, I do think it's important to put some of the findings that we just heard into a broader context. As I mentioned earlier, last week we witnessed major developments that directly shaped or addressed policies that support access and availability of care for many. However, we know that sexual and reproductive health care and well-being is shaped by many factors that are beyond the healthcare system. We are, of course, still in a pandemic. Many communities continue to struggle with poverty, poor housing, racism, and unemployment, and we have yet to address the longstanding harms of structural racism in healthcare and beyond. And of course, while many celebrated yesterday's verdict, the individual and collective trauma of the cruel and unnecessary deaths of young people of color and the ravages of gun violence is far from erased. These issues are all inextricably connected to individuals' sexual health and reproductive well-being. To help us put this all into a policy context, we have 4 great panelists who spend a lot of time thinking about and trying to improve the systems of care for sexual and reproductive health that serve millions across the nation. Going in alphabetical order, I'm going to start with Cammie Jeffrey, who is joining us from Austin, Texas. She's the CEO of Everybody Texas, which is the Title X agency for the state of Texas. Cammie has great expertise and a long history working in Title X and Medicaid, especially as it relates to sexual and reproductive health, and also has a deep well of knowledge of all things Texas as well as Louisiana. Sue Kendig is joining us from St. Louis, Missouri, in her capacity as the Director of Policy at the National Association of Nurse Practitioners in Women's Health. But she is also trained as a lawyer as well as a nurse practitioner. She's a national expert on patient safety and women's health, and also serves with me on the advisory panel of the Women's Preventive Services Initiative, which continues to make recommendations for preventive services for women to be covered under the Affordable Care Act. Turning now to Dr. Reagan McDonald Mosley, who is the CEO and Director of Power to Decide, formerly the Campaign to Prevent Teen and Unintended Pregnancy, and she's coming to us from Baltimore. She is still a practicing OBGYN and the former medical director of Planned Parenthood Federation of America and Planned Parenthood of Maryland. As a clinician and a national policy expert in sexual and reproductive health and equity, she brings a unique lens to her work. And last but not least, Dr. Monica Mclemore is joining us from the San Francisco Bay Area. She's an associate professor of family health nursing at University of California in San Francisco. Her research is grounded in reproductive justice, and she's an advocate, leader, and researcher that uniquely combines nursing, public health, and policy research to better understand reproductive health and rights for people with the capacity for pregnancy, as well as to inform policy and practice. Their full bios are posted on the KFF website. Before we get started with the discussion, I'd like each of you to take a minute or two, and I mean that, to touch on 1 or 2 of the findings that Brittany and Usha just presented that stood out to you, and tell us a little bit why. I'm going to start with Cammie, please.
Thanks, Selena. I'm so happy to be here today with all of you. And listening to the findings that were just presented, I think I found it most interesting that telehealth use was lower among younger and uninsured respondents. So the Title X provider network in Texas experienced a number of challenges with adopting telehealth during the pandemic. So this data point really made me wonder about where these respondents were able to access care. It made me think about the inequities within our healthcare system and the ways in which that system can be accessed and how that will continue to play out during and after the pandemic. So I know we're going to touch on a number of these topics during our discussion today, but those are kind of the themes that helped me frame my thoughts. The pandemic really forced many providers to make changes to the way they delivered services and to better ensure the safety of their clients and their staff. But this happened during a public health emergency where resources were strained. So while we did a lot to support providers standing up a new model of care, it was challenging and people really want to see their providers face to face. So I know we're going to have a lot of conversations about, as the field, as policymakers, as funders, about what we learned and how we can best support this care going forward. But I think it's really important that we're engaging providers and clients in those conversations about how we're best going to deliver care in the future.
I would totally agree. I think there's been a lot of transformation happening, and see what will actually be sustainable over time. And there's a lot of voices that need to weigh in to shape that. I'm going to turn now to Sue, please.
Hi, thank you for including me in this. And, I think when I read the report, there were a few things that stood out to me. Certainly, telehealth was one. I do think we need to be thinking about not only how it's utilized, but how people have access, the broader issues beyond women's health, like broadband issues in our rural areas. But some of the things that really struck me, and right now I'm looking at the graph on page 3 of the report, and if I'm reading this correctly, it looked like women ages 36 to 49 were less likely than the other age cohorts to classify avoiding pregnancy as being very important and somewhat important. And I think it's important to think about that age group as we think about women's health, because oftentimes we are thinking about reproductive and sexual health for younger age groups, and that is a group that is definitely at risk for unintended pregnancy. So that was something that struck me. And I think the third thing that struck me was the utilization of quality improvement measures, because I think it's a good start to look at the person-centered quality improvement measures that are coming out of NQF, but also I think we need to pay attention to congruity between the woman's intent and the reality of what she finally ends up with in terms of her women's health care. Thank you.
Thank you, Susan. I'm going to turn over now to Reagan. I got too many mucks, and so I always trip up on the alphabet there, but thanks to Reagan, please.
Thank you, Alina, for inviting me to be on the panel, and thank you to the Kaiser Family Foundation for doing this important research. So in terms of what stood out to me, I think I'll just double click a little bit on what Sue said, right? Like clearly there's a need for more person-centered and person-driven quality measures to gauge the effectiveness and high quality contraception counseling and care. And this is evidenced by the fact that in your study, 20% of people stated that they were not using their desired method. And this was as high as 27% for uninsured people, right? Moreover, over half of the people who were not using their desired method cited systems level reasons. It was too expensive, it was not available when they went, or the provider prescribed a different method. So the need for more person-centered care is also reflected in the fact that less than half of the respondents say that they received excellent care. And this was as low as 36% for Black women and 35% for people with low incomes. So looking at this data, it's no wonder, right, that like unintended pregnancy is higher in the United States than in many other places around the world. And we need to work to unabashedly ensure that the systems are redesigned to empower people to make the decisions that are best for themselves and their lifestyle. People are, after all, experts of their own lives, right? And centering the patient's desires has been shown to improve the patient experience as well as to increase uptake and continuation of methods. And centering people's desires and their autonomy will create an environment where they can more readily match their desires with their actions and support reproductive well-being for all.
Great. Thank you, Reagan. I'm going to turn to Monica now for her thoughts.
Well, first of all, I agree with much of what our esteemed panel has said, and thank you so much for having me. I'm going to take us in a different direction, though, and provide 3 points that I think are really, really important. The first is, as we think through routine care and missed care, I want us to caution us about, this is opportunities for blame. And I actually think that we really should pay close attention to the notion that, without a federal and coordinated response early on in the pandemic, let's make sure we put blame where it belongs, right? So as we frame our discussion, that's piece one. Piece two, I would like to engage in a national discussion about not an either or, but a both and around telehealth and in person. It works for some people, doesn't work for others, whether it's broadband or I want to see my provider like in person. I want us to adopt a both and approach to understanding telehealth because we want to tailor how people achieve services in a way, similarly what Reagan said, that works for them. The last piece I will say, and this is a hard one, but we're all surviving a pandemic. There is a collective trauma response around mental health that we're all not dealing with. So to try and parse mental health or mental health concerns, separate from this larger group experience that we've had over the last year, I would really let's all own the fact that we've been through one of the most traumatic years, at least in my lifetime. And let's sort of make sure that when we talk about mental health, that we talk about it in that global context, not just in the sort of context around, sexual and reproductive health, but that sexual and reproductive health, mental health is part of this broader experience that we've all had.
Thank you. I couldn't agree more. I think we have this tendency to compartmentalize sexual and reproductive health from your general preventive health, from your mental health, and we're all one package here, and all of that really does shape our health outcomes, and also how the health system needs to respond to make it better for us. Well, thank you so much. I want to turn now to some of the first questions, and I'm going to turn first to Cammie and Reagan because I want to start with Title 10. Last week, the Biden administration issued new regulations that will allow many of the providers who relied on Title 10 to return to the program, and those who remain to really change the way that they've been doing things in terms of referrals and abortion care. In addition, the regulation includes a more specific focus on equity as a priority, and that's new for Title 10. How do you think that that's going to affect care, and what do you think will be needed to strengthen the availability of family planning services, particularly for communities that have been historically underserved or excluded? Cammie, you want to get us started?
Sure. So, our organization has really viewed Title 10 requirements as a floor, not a ceiling. We are a relatively new grantee, received the statewide funding in 2013 around the time that the quality family planning standards were coming out from the Office of Population Affairs and the CDC. And so that is the model that we have worked with and always taken the approach, because access is so challenging in Texas and care is so challenging in Texas, that we can do more, we can do better. So it was really great to see the specific focus on equity as a priority in Title 10, because we know that not all providers or all grantees are doing more than the minimum. And that's not always because they don't view these other things as priorities, but they are juggling many other federal and state programs that have lots of priorities and requirements, and some of those compete with each other. So I think it's a really good first step to ensure that we're having conversations with Title 10 funded organizations about what they're already doing to engage clients and communities who have been historically underserved or excluded, what they can do to increase that engagement, to make sure that engagement is meaningful. And I think as we learn more about what providers are doing across the network, not only in Texas, but nationally, it's going to help us share best practices and identify areas of improvement collectively on state and local levels. And I think it's going to force a conversation about the origin of this program and this funding that I think many of us are ready to engage in, especially after the last 4 years, where it wasn't just sexual and reproductive health care that was at risk. It was Black people, it was immigrants, it was a lot of communities were at risk under the last administration. And I think these are all of the communities we need to be engaging about how we're moving forward with healthcare.
Yeah, I think some of the numbers that came out of the Office of Population Affairs, I thought were so striking, with a reduction from 3.9 million people down to like 1.5 million. So, we don't see the federal dollars being used to maximize. But I also heard that there are some alignment issues that you think need to happen, not just with Title 10, but in the broader context of federally and state funded programs. Reagan, I know you have some thoughts about this as well.
Yes, I have many thoughts. First, I definitely want to, of course, applaud the proposed rule, right? That we reverse the gag rule. It's definitely a step in the right direction, but it's important to reflect on, as you just stated, the current situation, right, of where we are. After implementation of the 2019 Title 10 final rule, the Title 10 program was decimated, right? So we lost more than 1,000 service sites. And as you stated, the number of people served went from over 3 million to 1.5 million in 2020, according to the Title 10 report. And services aren't even available currently in 6 states through the Title 10 program, and in many states, minimally available. So I think we have to first acknowledge sort of where we are and like the level of funding that's needed to get back to where we need to be. And I think acknowledge that, like, in the spirit of not letting a good crisis go to waste, we have the opportunity to build back better, right? We shouldn't just return to the old model where far too many people receive substandard care or care that was too expensive and out of reach for them, as the data even in your study dictates. Cammie indicated that they use the Title 10 requirements as a floor and not a ceiling, but I would argue we really need to raise the floor and not leave it up to individual sites and grantees to decide, the level of quality that they're going to implement, but make that standard. And as you said, there's an equity focus, which I think is great. The proposed rule states that there should be a focus of grantees on providing services in a manner that's client-centered, culturally and linguistically appropriate, inclusive, and trauma-informed, protects the dignity of individuals, and ensures equitable and quality service delivery. And this focus is important, it states, for especially for places that are serving low-income clients, right? And that's a beautiful vision, but it will take changing the standards of the Office of Population Affairs review process of Title X centers and subgrantees to focus on measurement of these things, requiring sites and grantees to measure how many people, especially people with the lowest incomes, receive the method of their choice rather than the one that they can afford. Do the patients receiving services through Title X feel respected and heard? These are the measures that people care about and communities care about, and that grantees should be held accountable for.
Thank you. Yeah, I think that there's going to be a lot of discussions in the coming year about modernizing the program. Is, really, I think many of us who really value the program and what it brings realize that the time is now for us to look hard and build a program that really responds to what people need. I'm going to turn now to a different topic, and I'm going to turn to Monica and Sue. Nearly 1 in 5 women said that they weren't using the contraceptive of their choice. And when they were asked why they weren't using their preferred contraceptives, 1/4 said affordability, and 20% said they were using what their providers recommended. What does this tell you about the existing gaps, particularly with regard to coverage and payment, as well as the need for more client-centered care? Monica, you want to kick us off?
Yeah, I mean, so first of all, I think at some point we need to have a discussion about reckoning around the cost of healthcare in the United States. So that's a whole other conversation that I think we need to have. And I think, the American Rescue Plan tries to get at some of the pieces of that in terms of making sure that the defunding of public health that we've seen has been a real problem. So I'm putting my hat on as the current chair of sexual and reproductive health for the American Public Health Association. We have been asking for a long time for strategic investments, both at the state and federal level, for sexual and reproductive health care, including increased and improved coverage around contraception, around family planning, around, birth options and birth spacing, right, from a reproductive justice perspective. So I think sort of a real overhaul in thinking about just the cost piece. But I want to put a pin in the provider piece, right? It was really striking to me that 20% of people said that they were using the contraception that their provider suggested. That's where I think we can actually do some work, because as a professor of nursing who trains the future healthcare workforce, we really know that provider suggestion, provider input, provider recommendations, provider information informs people's decisions, but it can't be coercion, right? I mean, and we've seen some good work, some mentioned by, earlier in Dr. Dellendorf's work and work with Dr. Ami Machinki Gomez, like we know that there are best practices that need to be infused across states, across geographic areas that really show that there's a sweet spot between patient preference and clinician recommendation. And so I think we have a lot of work to do, not just on the cost side and really thinking about how do we get people the services that they need over time, because those also might change. But then also, how can we really lift up the education of providers to understand how to curate a space to have evidence-based conversations with participants, but also eliciting what they really want and what they really need and what will work for them in their life circumstances.
Great, thanks. Sue?
Yeah, I think there are a lot of issues to really unpack here. Number one, in terms of affordability and coverage, when we think about, first of all, when I think about sexual and reproductive health, that is women's health. That is part of women's health. So fractionating these different parts of what encompass women's health really doesn't allow us to look at the whole person. So I think that, number one, is a really important thing. And when we think about some of the poor outcomes women are having, maternal mortality, and the disparate outcomes in terms of maternal mortality that everybody is trying so hard to work on. Well, when we look at coverage, for instance, in Medicaid expansion versus non-Medicaid expansion states, women who are living in Medicaid expansion states are more likely to have coverage prior to pregnancy and between pregnancies, thereby addressing all of their health needs, one of which would be contraception, versus those in states that have not expanded Medicaid. You've got about 50% or more of women who are not able to access critical care during those time periods, that would actually be something that tees us up to address part of the maternal mortality issue. And the people who are suffering the most from maternal mortality are also the ones that are disproportionately affected by not having access to coverage. So I think we do need to look at how we cover women before and between pregnancies, not just during pregnancy, as something to consider. Your report pointed out that Medicare doesn't cover contraception, and we do know that there are women of reproductive age who are on Medicare. So if you're dual eligible, I've seen instances where people have been denied coverage because of Medicare not paying. And is that a policy that needs looked at, or is that a local interpretation that is affecting how people access care? In terms of the provider issue, I totally agree with Dr. Mclemore. I was an educator. I coordinated a women's health nurse practitioner program for 20 years. And if we are not educating our healthcare providers of tomorrow, not only about all methods and how to counsel in a person-centered way so that you are actually partnering with women in coming to their decision as opposed to foisting your opinions. The other thing I would say about that is when we look at places where there is little access, our rural areas, for example, we know that we're seeing hospitals with OB coverage, either closing their OB units or closing the hospitals. When that happens, you tend to lose your women's health focused providers as well. So what do we need to do to shore up the abilities of the providers who are providing that care, and how do we set that foundation in our curriculum?
I've always think of the coverage issue as kind of the floor. Like, we need that. Without that in place, we won't have the providers, we won't have the systems. And unfortunately, the floor is still very uneven across the country. I'm going to now turn it back to Reagan and Cami, because I want to get back to care outside of traditional clinical settings. As Cami mentioned, family planning clinics really stepped up their efforts in telemedicine during the pandemic. And we've seen tremendous growth also in these telecontraception apps that Brittany was mentioning. And last week, the FDA suspended their in-person requirement for patients to get medication abortions during the pandemic emergency. So what are the implications of these models, do you think, for women in rural and medically underserved communities? And also, I worry sometimes, what does the growth of these mean for bricks and mortar providers as well? Would really welcome your thoughts. Reagan, you want to kick us off?
Sure, I'd be happy to. And, some of the panelists mentioned this during their initial comments, but, it's sort of like a positive negative, right, around telehealth. So the expansion options really have had the potential, and have during the pandemic, provided more opportunities for a person-centered experience. In my experience as a provider, especially during the pandemic, people have been so grateful, right, to not have to leave their homes in order to get the care that they need. But this is also true outside of the pandemic as well, right? Like, even in the absence of a pandemic, people have to navigate cumbersome, slow public transportation systems, take time off from work, arrange childcare. So all of these things are still going to be necessary for us to navigate even as the pandemic wanes. Technology has the potential to be a game changer, right? And it has been during the pandemic, but we also have to be clear-eyed about who is and has the potential to be left behind. And this is why your research is so important, so that our policies and practices can be driven by data rather than assumption and anecdote. In fact, I was actually pleasantly surprised to see in your briefing about women's experiences receiving care during the pandemic that Hispanic women and women with low incomes were actually more likely to have ordered birth control through a website or an app. But I also am left to wonder if that's because our traditional systems are not adequately serving these populations, right? It's a double-edged sword. So Sue and Monica touched on this in their opening comments, but I would say 3 things are really important for us to consider with the expansion of telehealth. Number 1 is, again, the infrastructure, and especially rural and urban areas, and the access to reliable internet, and especially a strong enough internet connection for video teleconferencing that's required in some states for telehealth. Number 2 is ensuring that there are low-tech options, right? ensuring that, phone visits are an option, asynchronous options when medically appropriate, and an asterisk that these are reimbursed by Medicaid and are options for uninsured patients, not just for those with private insurance. And a double asterisk that providers, need to provide the care based on patient preference and what's medically indicated, but not what's going to get them paid the most. And I think that's something that we don't talk about enough. And then lastly, let people drive where and how they want to receive care, right? Like let them have the option to choose if they want to connect with a provider by phone, telehealth, video, asynchronous, or come into the health center as long as it's medically appropriate for their level of care. And then lastly, I'll say we need to interrogate our assumptions and insistence that patients need to come into the health center, or we really, the pandemic has allowed us or forced us to do this really quickly, right? We used to require people to come into the health center for all kinds of things that we're now delivering telehealth for because we were forced to, but we need to continue to do that even after the pandemic's over and really interrogate our assumptions about when people need to come in and provide them with the most person-centered option for them.
Thank you.
Yeah, I mean, as it relates to abortion care, I just want to note, Texas is one of the 18 states that bar telemedicine provision of abortion care. So people in our state are not going to benefit from the FDA suspension of the in-person requirement for patients to get medication abortions, unfortunately. I know we talked a lot about telehealth, but during the pandemic, nearly 3/4 of our Title X providers across the state made and maintained modifications to their service delivery to support continued access, even when clinics had to close or reduce their in-person visits. And it was beyond just telehealth. We had providers offering contraception and STI testing via curbside and via mail. They supported self-administered depot injections. Curbside contraception was by far the most common modification that we saw. We saw our specialized family planning clinics do the most modifications and try to support the most access. And we also saw providers that had small volumes of patients in rural areas really try to figure things out. One of our clinics literally took a window ACU unit out of the wall and made a walk-up contraceptive window. I mean, that is the kind of work that our providers are doing because they understood the need to meet their clients and communities where they could during this pandemic. And I really hope that does continue. But as Reagan's already noted, I've worked in Texas long enough to know many of these innovations were not supported by payers before the pandemic. And we need to better understand what worked for both providers and for clients during this pandemic. And we need to be ready to advocate for what we want to carry forward, because we have to make sure that providers who are already operating on thin margins are going to be reimbursed. And as Reagan noted, that their decisions about how to deliver care are not being driven by what's going to get reimbursed, because unfortunately that happens in safety net clinics.
Yeah, those are, I think, what the future is going to look like and what's going to be reimbursed and how, what the incentives are going to be for providers is really going to, I think, unfortunately, shape what we offer rather than what's sometimes best for the patients. I am going to ask this one for our current and recovering clinicians. I guess that's Monica, Sue, and Reagan. I was struck that nearly 1/4 of women said that, that there's so few conversations that are happening there around counseling around STIs, HIV, and IPV. I think that gets back to kind of some of the earlier points that Monica was making about mental health, sexual health. There's so much more. We have a very big focus on contraception, and we have a lot of programs that are funded for contraception. I just got off of a National Academy of Sciences committee on STIs. We're going in the wrong direction when it comes to STIs. And I'm wondering what you think is working against clinicians having these sensitive but really important conversations with women, and what type of opportunities and incentives do we need to be providing? So let's start with Monica, who's nodding her head really hard.
Yeah, I have to say, I'm going to be addressing the Title X grantees next week with some ideas about this. And so for me, one of the first things I have to say is we need to think about new models of care delivery for contraception. If we think about, reproductive capacity as a spectrum, and we think about the de-siloing of, body parts and functions. Maybe we need group discussions to start thinking about, contraception experiences, like adapting from, sort of the group prenatal care model in the pregnancy space, and having people be able to sit and talk and learn from each other. So like having a peer-to-peer support situation. The second thing I will also say is that maybe we have such innovations in, contraception care and family planning, clinics. Maybe what we need to really start doing is sort of innovating a sort of tag team approach, going back to the both and of telehealth and in person. Right? Maybe there's some pieces of work that we do in a virtual environment, and there's some pieces that we do in person, and making sure that that's appropriately reimbursed, right? So that it's seen as this broader discussion as opposed to the, sort of 15 minutes behind the closed door discussion. Maybe we start to think about how can we innovate, the technology with the in-person and having that weave that curated space that people need to have some of these conversations. And then the last thing I think we need some simulation, right? I am ready to start thinking about how do we start to simulate and train clinicians to have some of these conversations, using, educational tools, using virtual reality, using some ways to help clinicians to start to gain some comfort around creating space for people to bring forward their own expertise so that we can have a shared journey over time to talk about what people need with the current partners or the future partners they're going to have, in the current economic situation they find themselves in the future economic situation they hope to be. Like, we can have a more life course discussion if we start to think about how do we integrate all of these tools towards a way to get at curating a space where we can have some of these conversations. Those are the kinds of things that I'm thinking about.
Great, thank you, Reagan. You're still in it.
Yeah, still in it, still providing care.
You were in your white
I would
coat when I
say-
saw you.
Yeah, I think I take this personally, right? And it's forced me to interrogate some of my own practices and where I may have biases. And I encourage all of the clinicians I work with to do the same, frankly, right? So I think from a training perspective, we need to lift up this data and acknowledge that we have as issues, as a movement, as a system, at sort of inserting our biases around race and class that continue to harm people and that are sort of embedded in our systems and institutions that lead to the fact that we like bang people over the head with the need for contraception and controlling their fertility at the expense of other general health needs, right? So I think that's number one, is acknowledging it and training it, lifting this up rather than shoving it under the rug. And, speaking about some of the systems and programs and the ways that has been perpetuated in the past. And then secondly, I think we need to measure it, right? What gets measured and reported out gets modeled. And so we need to have policies in place that develop quality measures that people actually care about, like was presented in your study. And not just look at the percentage of patients who use a LARC method or a highly effective method, but what percentage of patients were satisfied about their care or leave with their desired method, or were comfortable with their care, or felt seen and heard and respected by their provider. Was your primary concern addressed, right? We are often speaking past our patients rather than speaking to them. I had a conversation with a young woman a few months ago who said that she wasn't using contraception and felt constantly judged. She was berated every time she went to the health center. And the reason why she wasn't using contraception is because she had been having unprotected sex with her partner and hadn't been pregnant. And so she was actually worried, although she didn't currently want to have a child, but she was worried or concerned that she may not be able to get pregnant. And this conversation was never had with her provider because the provider was so fixated on, well, you say you don't want to be pregnant and yet you're not using contraception. And so the person's concerns weren't being addressed, and the provider felt frustrated because they felt like they weren't doing a good job. They were completely on different pages, really on different books altogether. And so we really need to create systems. And I agree with Monica that perhaps using some technology to do some initial screening and some structures can allow us to be more efficient and effective in our care delivery.
Thank you. I'm going to transition us a little bit to some of the questions, but I'm going to turn this one to Sue perhaps because it's related. What do you see as some of the promising models, both of innovation and technology? And I know Monica touched on some of it in terms of training, but are there models within the organizations that you're working with, and what kind of policies do we need to support that, the development of those models?
Good question, because those were the kinds of things I was going to respond to in the last
Excellent.
question. So awesome. Yeah, I totally agree with, you know, what both Monica and Reagan have said. And, you know, when I think about issues around concerns being dismissed and not including what's termed in the question as sensitive issues, I think we need to look at how we can support clinicians in accessing that care. So I'm going to share some models that actually, when I was teaching women's health nurse practitioners, that we use, that I think are still transferable and could possibly lend themselves to those simulations that, Monica, we're going to do. But, you know, back when I was teaching for, gosh, like 15 years, I partnered with the regional CDC-funded HIV STD Prevention Center. And we developed a program specific for the nurse practitioner students, started out with the women's health nurse practitioner students, and then said, you know, everybody's got to do this. And where they had specific coursework and they had immersion experiences with the STD clinics so that they were able to learn how to ask the questions, how to respond to the questions, how to be non-judgmental. And really watching that curriculum, you could literally see the implicit and explicit biases starting to fall away. So I think, unfortunately, as CDC decreased funding to those programs, that experience was gone. So I think we need to look at what is fundable. The other thing I think is really important, we spend a lot of time talking with providers. We send them to implicit bias trainings. We want to do all kinds of different trainings. But I think we need to really look at how clinicians can partner with communities so that they truly understand the community by walking in that community, not by being in their office and having people come in and developing. And again, in our nurse practitioner program, that was something that was embedded. So, you know, we were talking about structural determinants and structural racism years before this was hitting the literature. And it was because our community partners built relationships and built those experiences. And I think we need to look at some of that and build on Monica's idea of simulations, because, and again, this all requires funding. So for some of our federal funding streams, these might be some of the things in workforce development we need to be looking at.
And I just want to add one sentence. Can I just add one sentence to that, though? We also need to like trust and understand that the people we serve actually are our future workforce, right? So there's also this other piece of workforce development, which is the people we serve actually are our future workforce, not just that. So it's a both and again, in terms of when we think about like, why are we not using the doula model to bring folks into the health professions and then create the paths that they need in order to become the providers, since they live in that community and definitely have the capacity to care for that community.
We're drawing artificial lines where none really exist.
Yeah.
I thought, Cammie, I saw you looked like you were eager to say something here too. And I know you've worked in IPV in the past as well.
Yeah, I mean, I just think, you know, this is a thing that came up a lot with our providers, challenges around having those conversations during the pandemic, people not being able to get to private spaces, and that it was the challenge for telemedicine, for phone, for app use. You know, we had providers who encouraged their clients that had access to their own transportation to come early, park in the parking lot, and have that pre-conversation before your in-person visit, you know, in the car where it was at least private. And that's not, you know, that's not the reality for everyone, right? That comes to our clinics. And it was really a driver for us to get back to in-person. So I think it really goes back to what Monica was speaking about. Telehealth and these innovative models are going to have to be both and. They're not going to work for everyone. People are going to want to be face-to-face with that trusted healthcare provider to have hard conversations and get warm referrals to places that are providing supportive services. And this is more than just their contraception. It's, you know, when you're doing a sexual health history on the phone, you can't read your client in front of you. and understand what follow-up questions you need to have to understand risks around sexually transmitted infections, what behaviors people are engaging in. So I think, again, it's going to have to be a both and that, you know, confidentiality, which is a hallmark of Title X, doesn't happen in all those spaces. And so I think that is one thing that we really tried to drive home during this pandemic, how important that was. So we're glad to see the Title X rule come out last week and really recenter that.
And I add one more thing to that discussion as well. I think also many times these issues aren't addressed because clinicians don't know what to do. They don't know where to refer for support. They don't know who to call. And so utilizing the technology now, we can actually develop resources and resource lists so that if I don't have the answer, if I don't know what to do, I know where to find my best friend who can help. And that's what it's all about. So leveraging our technology for that interconnectedness in communities.
Well, clearly, we could spend another hour, 2 hours, or days discussing a lot of these issues, but I'm afraid our time has run out. But before I close, I just want to remind the audience that the recording is going to be on our website. And that this slide deck, and we have 6 separate briefs highlighting different findings from the survey. So they're up on kff.org. I don't know if you want to put up the slide there, Robin, or whoever's steering the ship. But anyway, all the registrants, you're going to receive an email with a link to the recording and all these briefs when they're posted. I want to thank Usha, Brittany, and Michelle for all their work on this survey and for their presentations today. And an extra special heartfelt thank you to the panelists, Cami Jeffrey, Monica Mclemore, Sue Kendig, and Reagan Mcdonald Mosley for sharing your time and your wisdom today, and most of all for your tireless efforts to improve sexual and reproductive health care and well-being for all. Thank you from the bottom of my heart.